right, good morning again, everyone. I'm Melanie Marcus from SureScripts, and we are thrilled to be a sponsor of the annual meeting this year. I'm also thrilled to introduce this next panel, the Whole Person Integrated Care Panel. So as I was thinking about this introduction, I was thinking, what can I say to make an impact here? And it came to me that maybe I should tell a joke. I'm not an inherently funny person, and so I did what many of you might think to do in this room, in this situation. I consulted ChatGPT. I literally put the description of the panel into ChatGPT and said, help me tell a joke to introduce this panel. And here's what it said. Actually, ChatGPT ends up being kind of cuttingly funny. I've got two. Interoperability in healthcare is like trying to organize a family group chat. Everyone, doctors, pharmacies, labs, telehealth, needs to be on the same page, but half of them are using different apps. The pharmacist only responds to texts after 9 p.m., and the lab keeps sending emojis instead of results. Hopefully today's panel can help sort this out. That was the first one. And then I was like, well, I kind of want a question and answer one, right? So I asked it, tell me another one with question and answer, and here's what it came up with. Why did the lab, the pharmacy, and the telehealth provider walk into a bar? Because they heard it was the only place where they could finally connect. All right, so with that, it's ChatGPT. With that, here's the panel.
All right. Well, thank you, Melanie, for that nice introduction, and ChatGPT for those jokes. I have the pleasure of leading a great panel today. My name is Ben Rosen. I'm with Netsmart, and I think to start us off for whole person integrated care, right? That's a pretty broad topic, we'll say, just like interoperability is in general. I want you guys to kind of think through as you're hearing our panelists speak, that these representatives here kind of represent a little different part of what we would maybe think of with whole person care, maybe what we're traditionally used to when we talk about things like treatment use cases, et cetera. So I think we'll start with just maybe a minute or two if you guys do want to introduce yourselves first, and then I have some questions I can kind of get to. And then at the end, if we have time, we take some questions from the audience.
Sounds good. Good morning, everyone. Pooja Babbrah. I am the Executive Vice President of Strategy and Industry Alignment for NCPDP. If you're not familiar, NCPDP is the standards development organization really focused on pharmacy standards. I am new to this role. It's a brand new role that NCPDP created for the very reason that we're starting to see an expansion of the role of the pharmacist, and we're really starting to talk about how we can pull pharmacists into the care team and exchange clinical data and really pull them into TEFCA and all the data exchanges. So excited to be here. Thanks for having me.
Wonderful. Good morning, everyone. I'm Jaffer Traish. I serve as the Chief Operating Officer and on the board of FindHelp. FindHelp is a social care network and closed-loop referral system software. We also own and operate School Care, which is a K-12 electronic health record for schools across the country. And just to share, Nicole mentioned on a previous panel tipping points. We're part, I believe, of a tipping point where we see over 1 million distinct US adults navigating for social care every 2.5 weeks through even just our digital technology. So it's a fascinating place to be in the center of whole person care.
Hi folks, my name is Matt Becker. I'm the VP of Interoperability at Node2. Node2 is really concentrated on being a connectivity platform for those who did not necessarily receive a lot of the money that was involved in making sure that interoperability could happen across the ecosphere. We concentrate a lot on long-term post-acute care, EMS, therapy, home care, things like that. When part of the reason we're on the whole person integrated care panel is to really bring all those together and really help understand the very important role of those groups within the framework of healthcare and really advocate for making sure that they can not only play a part but actually help improve patients' lives with the other folks that are involved.
Hi. Hi, everyone. I'm Stephanie Broderick. I'm the Executive Vice President of Strategic Initiatives for Clinical Architecture. Clinical Architecture is a company that focuses on helping healthcare organizations, health systems, payers, health information exchange, basically anybody that's dealing with healthcare information, and to help improve the quality of that data.
All right. Well, thank you all for your time today and introducing yourselves. So I have some questions here that will kind of get our conversation started or going here. So I think, Pooja, first, my understanding is you work with the Interop Matters Pharmacy Group. Can you tell us a little bit about that and kind of some of the use cases you guys are discussing, and then kind of big parts of those, specific pharmaceutical use cases?
Yeah, absolutely. So last year at the annual conference, we had a panel on pharmacy interoperability. That was a result of the HITAC committee actually had back in 2023, a task force. It was a pharmacy interoperability and their emerging therapeutics task force, long title. But I was able to serve on that along with a lot of the folks that were in this room, Dr. Stephen Lane, Anna McAllister, and Hans Budacek as well. We made 34 recommendations to ONC about pharmacy interoperability. And it really stemmed from the fact that we saw during the pandemic, right, pharmacists started to play a big role in improving patient outcomes. We were doing vaccines, they were doing the testing for the COVID, for COVID. And so it was really focused on how do pharmacists start to get into the conversation about interoperability, not only just for the next public health crisis, but beyond that as well. A couple of those recommendations were really focused on how do we start to introduce pharmacy and pharmacists to TEFCA? How do we start to think about clinical data exchange? And so, it came out of last year's panel. We asked Sequoia Project if they would be willing to host a pharmacy interoperability work group. And hats off to the Sequoia Project folks for supporting us in that. And of course, as Melanie mentioned, SureScripts as well. And really our goal is a couple. There are obviously some barriers, right, and some challenges in trying to get pharmacists onto TEFCA. First of all, I've been in many rooms where I have people raise their hands in the pharmacy industry to say, do you even know what TEFCA is? So part of it's just education, right? And we have treatment use cases, we have things, but pharmacists aren't necessarily involved with that. I thought yesterday's conversation was great about the what is treatment, because as we started to think about pharmacists, there's really a couple use cases we could be thinking about. One is they're just dispensing a med, right? You don't necessarily need access to a patient record for that. But if you are now starting to, you do the test, you actually prescribe Paxlovid, all of a sudden you're treating. So, do they fall into that treatment use case? So part of our goal for the pharmacy interop work group is going to be about just defining those use cases and also figuring out barriers. So if we think about, pharmacy tech vendors, they are not certified today. That's something that also came out of the ONC recommendations was, should we be certifying pharmacy tech vendors? We did NCPDP has a foundation, and we funded some research that basically went out and we talked to pharmacy tech vendors. We found out that most of the pharmacy tech vendors are actually FHIR enabled, which even surprised me being in the industry. So things like that we're starting to look at. The other goal I think that we want to kind of figure out is, what is that data set that we would want for pharmacists, payers, and providers to exchange? There's USCDI, right? But is there things beyond that? So maybe defining a data set. And then the last thing, I think, I heard this at the patient panel yesterday, which I thought was really great, was, trying to figure out this toolkit, right? So what are the barriers that we need to remove? What can we be sharing back with the members of Sequoia who maybe want to start talking about getting pharmacists on? It's all about care coordination, and pharmacists can make a big difference in that patient outcome. So those are kind of the three goals of our work group.
Well, yeah, that all sounds great. And I think you made a really great point about, specifically with the pandemic and kind of being pharmacists being thrust into those kind of treatment roles, right? So, they're always involved as the care team, part of the care team, right? We all know that. But now they're kind of taking maybe a little different lens with things like the Paxlovid example. And just needing to be part of the conversation around data exchange and getting that data. So that's a really interesting point. Jaffer, selfishly, FindHelp's a cool company. I dig FindHelp a lot because social determinants of health is really near and dear to my heart, and are social factors for those who are savvy, I guess. But so, can you talk about some of the stuff you guys are doing? My understanding, and the privacy panel before us talked a little bit about kind of like the New York waivers and stuff like that. And when we discussed before this, you had mentioned that there were some things going on in New York with FindHelp. Can you kind of talk about that project a little bit and kind of what that means just to the landscape overall for CBOs? And
Yeah, absolutely. So I think there's context here that's so important. There's about 1.2 million Tax 990 forms where organizations claim that they're a nonprofit. And a lot of those are just tax shelters, Little League fields, libraries, other centers. And that's a good thing. But when we whittle down, who are those organizations that are alleviating poverty? And that's really what this is. We all call it different things, but it's lifting people up. And there's about maybe 300,000 direct free and reduced cost services in the United States. That's a massive number of organizations to try to connect with and orchestrate care coordination with. And it's one of the last remaining markets in the US that is mostly undigitized. And so we're working on this really gnarly problem of digitizing this really under-resourced but important sector that is the supply side of the US social safety net. So New York did something interesting. They said, we're going to create 9 regional hubs. And we're going to make it the state's responsibility to use the SHINY, the health information organizations, to pass Medicaid eligibility information and enhanced eligibility information for reimbursable services through the SHINY infrastructure to these 9 regional hubs. That immediately puts in the hands of community health workers and care navigators who qualifies for a reimbursable social care service. And then those hubs can directly make referrals to contracted and non-contracted community-based organizations in those regions. And so now combine that with codifying all of those transactions with LOINC codes, SNOMED codes, and Z codes with a state definition in collaboration with the Gravity Project, and all of a sudden we have the first ever in the country truly formal, scaled codification of SDOH activity that then will be sent through FHIR bundles back into the SHINY so the state data lake and the aggregators can do public health, can do supply-demand analysis, can decide how grant money should be used to better support the Medicaid population. And we're like 2.5 weeks away from go live. So we're ready to put the pedal down on this effort. But this is a really fascinating collaboration of many vendors, over 20 payers, the state government, standards organizations to really lift up the community. And I think what we're seeing across the nation, just to kind of apply this to scaling, we've seen 3 models. Model 1 is a state government forcing a 1-vendor monopoly and 0 interoperability. That's what we saw in North Carolina. And the US senators in North Carolina are quite displeased and even wrote to Secretary Becerra of their displeasure with what happened. Model number 2, New York. Let's create regional hubs. Let's create more choice. Let's create some degree of interoperability and use the state HIO infrastructure that they've invested in heavily as a central aggregation point. And I think that's getting much closer to a healthy solution that also respects CBO choice and consumer choice. And I think the third model is where there's point-to-point referrals to community organizations that are becoming digitized, and also state-level aggregation of the information based on consumer choice and where community organizations want to share that private data. So I think we're going to see those 3 models evolve, in the country and really, start to shake out. We connect with about 24 HIO organizations across the country today, in various aggregation models. So we're at that tipping point.
Okay. Great. Well, that all sounds really exciting. And I think, too, what we're going to see is almost a catalyst with, the HI1 rules and the US CDI kind of coming out and saying this is an SDOH assessment now versus we think these things are part of an SDOH assessment. So they're really clearly defining and hopefully just giving you guys more ammo to kind of go out and, really implement these really cool protocols you're working on. So, Matt Becker, So, you mentioned kind of Node 2 being kind of the connectivity platform, and you and I work closely together on a lot of things, specifically, LTPAC spaces and things like that. So the underrepresented populations, we'll say. So let's switch gears a little bit because we are at the Sequoia annual meetings and care quality. And you guys being a designated QHIN, can you speak a little bit about kind of maybe just the broad-based, is TEFCA the answer for some of these things we're discussing with the data pieces? Or, and then from the lens of maybe even potentially what these other exchange purposes could mean for some of these niche initiatives that we're discussing on this stage?
Yeah, to immediately answer the question of whether TEFCA is the answer, man, I really hope so. This is incredibly personal for me and for my family. And as someone with a chronic condition and someone whose loved ones also have chronic conditions, TEFCA is really the promise to solving the puzzle of healthcare for me. The idea of, if you look at it like just a jigsaw puzzle, we're working on the edges first. We're working on acute care, we're working on primary care, which are both incredibly important in solving that puzzle. You need to treat the symptoms. You need to have that 15-minute visit to get where to go next. You need to understand what is going on in order to get to that next step of healthcare. What I worry about is that next step of healthcare that has been so critical to me and others in actually solving that puzzle, solving what those next steps actually are, and to make the whole person better, has, even in the last 2 days, been only barely talked about in the grand context of the stats we put out, documents shared. 70% of hospitals are connected to care quality. Those kind of stats leave out the whole person care that is really critical to actually making people's lives better. And they're such an integral part of it that I don't want that to be dismissed. But at the same time, if you only do the edges of the puzzle, you're not actually going to get to the inside pieces that are really the critical to actually making the whole puzzle a reality and form a beautiful thing. And so when I say we concentrate on those edges of healthcare, that's where it becomes very important to make sure that we're talking about each of these areas in a very direct way, and making sure that not only they're included, but I know folks that work with me on TEFCA, folks that work with me on care quality, and have heard me kind of rant and say, we need to include these folks. We need to make sure that the barriers to entry are as low as possible. We need to make sure that this is cost efficient as well as trusted. All of that is that big piece in filling in that puzzle to make sure that those folks, those patients that really need that care at all of the edges of healthcare, get all those puzzle pieces in place, and sharing the data with each other so that you don't have a puzzle piece living in Oklahoma that you need in Arizona today, and vice versa, to make that puzzle complete, because unless that puzzle is complete, that person doesn't actually get better. And it's not a thing that's solved overnight. It's not a thing that's solved with one transaction. It's solved over time by coordination, and communication is an incredible part of that coordination. So the answer is, I really hope so.
All right. Well, great. Well, thanks for going into that about TEFCA overall and some of your personal story related to that. Stephanie, I have a couple questions for you based on some of the stuff we've discussed, but for the audience themselves, some of the things you're working on from some of the lab groups you're associated with, can you kind of go into some of that? And then specifically around that, I have another kind of pointed question around some of the reports that ASTP just came out with regarding some messy data in the lab spaces. So if you don't mind. Yeah.
Sure. So clinical architecture has been a member of Sequoia since the end of 2022. And we have actively participated in the data usability work group. And I have to give a shout out to the chairs of this group. They have been absolutely amazing at facilitating the team. So Dee Dee Davis, Dr. Greg, and Dr. Adam Davis have just been amazing stewards and leaders of this group. Last year, the group put out its first implementation guide focused around things like provenance, effective use of codes, effective use of narratives, and it was very much a process of taking the leaders in the group and asking, what are the pain points around healthcare? And one that emerged that we really didn't focus on in the first implementation guide then took prominence with the second implementation guide, which was just released yesterday. Again, hats off to that group, because I know they put a lot of work into getting that out. But what emerged was the need to address challenges around lab interoperability. And lab interoperability is something that we have a lot of expertise in at Clinical Architecture. It is a very non-standardized, very messy area, a domain of data. And so there was a new team that was formed called the Tiger Lab team that we participated in. I thought it was interesting that we actually didn't have any lab companies join until fairly late in the process. I think LabCorp did come to the table, but they weren't there initially, which I found interesting. So the new implementation guide that got produced yesterday, the main premise was that paper isn't just going to cut it anymore. Things need to be electronic. That we need to have discrete data. That we need to have effectively coded data, and the data needed to be shared utilizing appropriate standards. And so the team did a great job of putting together their recommendations for what needs to be done from a lab interoperability perspective. There were also some additional assets that were brought to bear. So there was a list of high priority labs that the group produced with recommendations to make sure that healthcare organizations are effectively handling those labs. Additionally, we had an amazing presentation from MIT where they had created a whole workflow for how lab interoperability works, how the standards are established. And what was astonishing to me was just the number of points of failure in the process where things can break down. Again, I highly recommend that you guys take a look at the new implementation guide, I think that it will help. Obviously, there's still a lot of work to be done. There are a lot of things that are queued up as we go into 2025 of things that we need to work on, but it was a really, really great first step. And then, lots of participation with, groups like SHIELD, with Livid, lots of people working on this. And so I'm really excited with where it's going.
Great. Well, thank you for going into that. And I kind of have a little bit of a follow-up question for you,
Yeah.
Specific to going back to kind of the TEFCA lens of what we kind of discussed with those exchange purposes as we continue those conversations at this conference, right? Like what's next for exchange purposes and things like that. I think the public health lens of the CDC kind of coming out with the e-labs, the e-case reporting. And can you just maybe spend a minute and talk about how, my experience today, at least with Netsmart, right, is we have rural labs that need direct integrations directly to them. Then we have, aggregators or groups of labs that kind of facilitate change or LabCorp, like you mentioned. Do you envision from the TEFCA side that, we'll hopefully be able to start standing up, like you said, next year, maybe we'll start standing up some of those labs going across TEFCA themselves, and kind of what that means, not necessarily difference in what the integrations are today, but just maybe how, kind of like what Jaffer was saying with the SDOH data and stuff, and being more standard, I guess.
Yeah, I think it might already be happening, and I may be wrong, but
yeah.
So we work with the Association for Public Health Laboratories,
okay.
And so we are helping them with converting their electronic lab reporting from CSV to HL7V2 so that it can be exchanged. We also are working with them on creating rules around the notifiable diseases, and it's incredibly challenging. There are 100 different jurisdictions that you have to go to find out what are their rules. And so it makes it very, very challenging. But I believe that eHealth Exchange, they're doing the ECRs. I think they're also working with the Association for Public Health Laboratories. So I think it's already happening.
Yeah.
One of the things that was really interesting to me, and I actually went back to my notes from my attendance at the 2022 annual conference. And it was my first exposure to Sequoia. And I remember coming back and I had to write a whole report. And I had in my notes, I've been a part of a lot of different, bodies like this, NCPDP, HL7, and I had kind of been out of the limelight for 6 or 7 years. And so Sequoia was my first thing. And I remember thinking, my gosh, these people are working so well together. They're collaborating so well. They're making such incredible progress. But I went back with the one note that said, okay, ONC is working great with CMS. VA is involved. NIH is involved. CDC is a work in progress. And so when I started looking at preparing for this, I was actually stunned at how much progress had been made on the public health side. And looking at the regulations that are coming up in HTI 1 that are being implemented now, and then what's being planned for HTI 2,
Sure.
It is clear that public health is a huge part of what TEFCA can bring to the table. And I was thrilled to see things like prescription drug monitoring programs. With my background, I think Pooja, that's a big deal. And so, yes, I think that it's going to take time. I think that public health is underfunded. And so they struggle with funding. You've got state regulations, you've got resource issues, but I think it's going to be like everything else with TEFCA. It's going to be steps.
Yeah.
And absorbing more and more as the industry can handle it, as the processes can handle it, the infrastructures can handle it. So.
Yeah, great. Yeah, I mean, I completely agree there, and I think too what we're going to see hopefully is, some of the right now we see a lot of required things around you have to report certain public health things, or it's in the best interest of a specific organization to participate in something. So hopefully what we're going to see is more facilitation from that side, especially with like a network like TEFCA to say, not only required maybe still to do that, but it's a lot much easier and much more standard, I guess, when we approach those things. So I think, Jaffer, I wanted to come back to you real quick. I know you talked a little bit about scalability, and I kind of wanted to pose a little bit of an interesting question, because we were talking about New York, and there's some specific things. I think a lot of us in this room have dealt or worked with New York, whether it be RIOs or, kind of what you mentioned with the specific waivers or their specific consent policies. Do you see and I know you said you're a couple weeks out from a go live, but do you see yourselves kind of being able to maybe take this to other states and maybe specifically bringing that towards and kind of keeping it in the lens of like a standardization approach to things like this? Because what I've seen from my experience is it's very difficult to capture, essential data that a CBO would really need to have, and then if you do capture it, is the CBOs can't even receive it or use it, right? So.
Yeah, absolutely. So I think what a lot of folks that aren't in the weeds of social care may not see is that the social care work is happening in the communities. Even though healthcare has a significant appetite to want to do this work, including for reimbursement, cost management, care quality, there's thousands of schools, there's churches, there's employers, Amazon, Target, Home Depot. They're navigating on behalf of their employees. There's 35 state agencies, that we work with that are doing this. 12 state governments, overall. So much of the work is happening, and much of that data is residing within the communities where that work is happening. So we're forced to think creatively about how to manage that data sharing in a way that is very cognizant of the person's interpretation of what information is sensitive. We can respect 42 CFR, we can respect state rules, federal rules, but at the end of the day, that person may consider just that food pantry experience as sensitive and private to themselves. And so we've had to come up with a model where each individual can consent for that referral and then specifically indicate and see who that information is then being shared with and what information as part of that transaction is being shared. So today I can log in, see that my information can be viewed by 4 health systems in California. It's demographics, 7 referrals, and XYZ notes. And I can control, as a consumer, which organizations see that based on where I travel, where I move, and so forth. And that was hard. That was hard to develop, design, and do. We showed it to Mickey. He really liked it. But I think that's something that we have to be cognizant of in this space. I think that extends to the challenge of when data is created by a community organization, it's not HIPAA covered. There's nothing that protects that information. So whatever system or vendor convinced them to sign up to do this documentation, they may ask for ownership rights of that information. They may ask to sell it. They may ask to do what they will. And so, in California, Assemblymember Weber and San Diego put forward Bill AB 1011. And this bill was only 2 paragraphs and had broad support and essentially said, vendors can't sell people's private social care information as a product just to profit off of. And I think it's passed 111 to 0 through several committees so far. And so, while there's a lot of talk of we can over-engineer this, I think we have to look at markets like, social care communities and make sure that we are making up for where there are some of these gaps, in coverage. I think the last thing I'll share is, one of those major silos that still exist today is in the education space. School nurses, guidance counselors, they're the first to know about an asthma attack with no diagnoses ever happening. They're the first to know about a 2-liter bottle of Coke being brought to school by a child because they can't afford lunch. They're the first to know that insulin management is happening because the refrigerator's broken at home. And today that information gets stuck. And very rarely does that get to a primary care, a payer, or someone to help that family or that student. And so part of our ambition is to work with many of you in the room and work with many states to escalate those risks and challenges with parent consent so that care coordination can happen and serve more people. So hopefully that's helpful.
Yeah, no, that's a great point. And I'm glad you brought that up because, when I started, when we got up here, we kind of mentioned this will be a little unorthodox as far as what we think of as a care team and the whole person approach. And you just hit that right on the head by saying, think of it from like a school nurse's perspective. Like that's not something you necessarily would think of from a person as part of a care team. But to your point, it's obviously very crucial clinical information, specifically around adolescence or child health. So that's a great point. And I think, Pooja, I have one more question for you before we get kind of the closing. Jaffer mentioned it a little bit, kind of some of that sensitive information potentially. And I know, as you kind of mentioned with the Paxlovid stuff, all that things happening in the pharmacy work groups, do you envision kind of how we have, 42 CFR sensitive data being treated today? Do you envision that, I don't want to say being an issue, but how maybe can pharmacists help champion or kind of get around some of those really specific guardrails? Because as you know, it's, sometimes if the consents aren't very specific down to the patient level, then you just don't get any of the data. So
yeah, and I actually want to address what Jaffer just mentioned, because I think pharmacists are in a similar situation, right? They know when a patient comes in and you're giving them something that needs to be refrigerated, and they say, I can't do this because I'm homeless right now or whatever. Like that's the information that a pharmacist is getting as well. Mm-hmm. And so, when we start to think about how are we going to get pharmacists involved, how are they going to access data, everything we've been talking about here, consent and, being able to access information, being able to know what to share back, it all applies to pharmacists. So I guess my goal, as we're thinking about the whole person care and the connected care is, we really need to be thinking of pharmacists as part of the care team, just like the nurses, just like, the other folks in the, on this panel, is how important of a role that pharmacists play. You brought up the Paxlovid example, and I think, the example I always use is we all kind of cheered, right, when we found out that, hey, we can go to our pharmacy, we can get a vaccination, we can get tested, and now they can prescribe. But the problem was, the pharmacist, just like the provider, needed a creatinine level, right? But how many pharmacists in a community pharmacy or in a retail setting, unless they're connected with a clinic, would actually have access to that? Yeah. So I think it comes down to, again, like how, what's the pharmacist doing? What are they hearing back from the patient? What are they allowed to share? And to your point, like the whole concept of consent is going to apply in the pharmacist situation as well.
Yeah, no, that's a great point. I think the theme we're kind of seeing between all of you guys is the representation of maybe the different data points and things like that, and is just like getting access to that data, and can we get out of our own ways almost in some of those places. So Go ahead.
Yeah, I was just going to say, to follow up on that, it's not just getting access to that data, it's being able to share that data back in a meaningful way.
Right.
I think to Jaffer's point and to some of these other folks, it is that communication that needs to go both ways that I worry isn't happening today. If you look at any interoperable system, like there's just a list of documents from a lot of different sources. How do you make sure that the physician is seeing or the clinician is seeing the right one at the right time? And the fact that like we're talking about a whole person here really is hard when you have so many different data points from so many different sources in so many different formats, quite frankly. How do we make that all really work together from both sides of the equation, not just quote unquote sucking up the data from the hospitals? It really is a two-way street. We need to make that two-way street work really well.
One of the really interesting conversations that we had as part of the Tiger Lab team, I think it was Texas Health Authority, brought forward examples of exchange of lab information and how it was being passed over and then displayed to the clinicians, and how different it was and how things weren't grouped together appropriately. And so that was some of the guidance to, I remember seeing screens, it was like you had to scroll 5 screens to see all of the labs because they were not arranged in a way that made any sense. And now you've got this cognitive dissonance, you know, that the physicians are having to go through. And so we came up with recommendations on how that would be addressed, both in how the data was exchanged, but then also how it should be displayed within the EHR, which was great.
Yeah. Did you want to say something, Jaffer?
Yeah, no, I just wanted to validate both of those comments and you know, share the perspective that there's so much stigma. And that stigma isn't just social care. It's medication management. It's my housing situation. It's you know, my personal experience going through my cancer treatment. And at the end of the day, I believe that patients, people like us, each of us, may be comfortable with understanding coalition of providers and of that care team. And I think a lot of us over the last couple of days have talked about the transparency. And I do think there's a lot of stigma. I talk to a lot of community organizations and community leaders who say there's this fear that anyone can go look up anything about me. And whether that's true or not true, that is reality. That's the perception, at least, of those community members. And so how do we help them better understand the coalitions that can form? It could be a housing coalition. It could be a you know, cancer support coalition. And those entities give them, I think, trust in how they're being cared for. So anyway, yeah, much more thought needs to be put into those concepts, but we are seeing some of those coalitions form in California with the Ask Me pilot in several counties and others.
Yeah. No, great point. And I think, you know, as we get kind of close to the end here, and this isn't directed at any one of you, so feel free to chime in. You know, typically you end something like this with like a call to action, right? I think I want to kind of maybe go a step up and say, you guys have all described some great things that are either in flight or maybe planned for the future use in 2025, which goes along well with kind of how we're seeing some of the TEFCA stuff play out and just in general. So whoever wants to go first, or what can we maybe get to our audience about around just, again, reiterating the importance of the things we discussed, the whole person care, the treatment teams and things like that, but then maybe thinly veiled into a specific call to action?
Yeah, mine is really simple. You got to think about the whole person when we're making large national judgments on what's going to happen with data interoperability. The biggest thing for me is making sure that everybody at the table is included, because unless everybody's included, that is treating the patient, then something's going to fall through the cracks and the patient's not going to get treated.
Good point.
Yeah, and I'll just add to that. I think that, you know, the point that Matt made earlier about lowering that barrier to access, right? I mean, think about pharmacists and pharmacies and, you know, situations also they're in community pharmacies maybe where, you know, they're you know, elephant in the room, right? Struggling on reimbursement and things like that. So be thinking about how you can include all the different care members and what you can do to help do that and make it easier for them.
Yeah, great point.
I've asked several people why it is that lab is so unstructured, right? Why are there not better standards? Why are there not better guidelines? And I have to be honest with you, I haven't really gotten an answer. And so I think that that's something that needs to be looked at. The whole industry, right, with ARA and high tech and, you know, TEFCA and the whole industry is facing this need for standardization, the need for good data and diagnostic data in the forms of labs is incredibly important. When you go to the doctor, one of the first things that they do is they send you to go get your labs, right? And it's a huge indicator of health or disease. And so I would really like to see there be more of an effort to push for standardization around labs.
Yeah, great point.
I guess I would say broadly on whole person care, I was joking with Mickey on a call one time about his plaque about CCHIT and certification and what that allowed to push forward. For any of these areas that we're talking about, for example, social care is only going to be more reimbursable over time, but how do we make sure that beneficiaries, patients, people aren't denied the opportunity to go where they choose and get that reimbursable service? And that might mean certification of vendors and their APIs to make sure that they are following standards, they are following FHIR, they do have the right privacy approaches. And if you play the game correctly, you can be a part of that ecosystem. So I think we have to think about what certification may be the wrong word, but how do we make sure we're creating the guardrails, the paved paths to support vendors following the rules?
Yeah, no, great point. And how can we enforce the standardization without making it, hopefully more costly to providers or people using the solution? So I want to thank you guys tremendously for doing this. I'm always going to champion the efforts of what I'll say like an underrepresented piece or something like that. So what we're seeing, and to Matt's point, we're seeing some of the delegation in the federal level to kind of coming around, which is where hopefully what it should have been the first time, right, with meaningful use, but underrepresented populations and things like that. So the things you guys are doing are great and are going to help those efforts completely and hopefully get some of those dollars down to where they need to be. So I think we have a couple minutes left. If anyone in the audience wants to ask our panel a question about anything they've heard today, I think there's 3 minutes or so. Dave, let me get him a mic.
One of the issues that I hear when dealing with whole person care, there are hundreds of thousands of frontline small agencies whose interoperability is email and a spreadsheet. Yeah. We talk about all these large organizations, right, like pharmacies, like labs, things that are well established, which need to be connected, absolutely. But so do these frontline agencies. They're dealing with maternal health, behavior, substance use disorder, on, and everything SDOH. And they can't get connected. I mean, I'm a big proponent of TEFCA for obvious reasons. How do we get them part of this so the information that's created by them, and they need to support the hundreds of people, the dozens of people they deal with on a daily basis, gets to them so they can do the best job possible?
That's a great question. Does anyone want to take that one?
Yeah.
I'm looking at Matt.
It is the ability to make sure that you obfuscate as much of the crap as possible, to put it quite frankly, of like, this is very hard to do. These standards are a bear, but at the same time, what we try to do, I know what others try to do, is make sure that these folks can have access to that through a simple method. And when we've connected thousands of EMS organizations. We've connected the groups that you're exactly talking about, and that's how, is to make sure that you take on the brunt of the complexity so that they don't have to. And without organizations that do that, then they are going to be left out. And then it's also the advocacy for those groups, because at the same time, just to reiterate the point, like with those barriers to entry, no matter how much you take away technically complex, if you don't make it operationally easy, it's not going to happen either. Thankfully, we've made progress in doing both. It's not perfect. The promise of TEFCA in the future is that it will be. We need to get there.
Yeah, go ahead.
I just want to say, I'll pick on CMS and CDC just for fun here, and that there's, the waiver in New York is $7 billion. The waiver 5 years ago for North Carolina was $650 million. This isn't small change. If they're going to expect this work and this collaboration, where is the funding to support these small agencies and these organizations to level up their technology, adopt a system that supports FHIR, and so forth? So we have to think about that infrastructure and not private equity-led companies, getting money.
Yeah, great point. And I think, Matt, to your point too, and Dave, great question, because you kind of think of these like crisis intervention teams, right? The jails and the things that are instituted at the state level to say if something's happening, you have so much time to kind of enact. Like it's almost like a domino effect to where, yes, we thought about the whole person care and some of the things we've represented today, but then there's almost a bunch of people in line after that are in the same situation, right? So, Jaffer, great point about the funding and things like that. So, I think we're at time, but again, thank you guys for your time today and for your all participation.